It hits you out of nowhere, a sudden, blinding pain behind your eyes or at the base of your skull. Your mind immediately jumps to the darkest conclusions, a ruptured aneurysm or a brain tumor. But when internal medicine experts encounter a patient in agony, they don't panic. They consult a rigorous, methodical framework, the kind detailed in foundational texts like Harrison's Manual of Medicine. And inside that clinical framework is a deeply counterintuitive fact. The actual intensity of your head pain is a poor indicator of whether or not you are in real danger. Statistically speaking, the vast majority of patients arriving at an emergency room claiming they are having the worst headache of their lives are not facing a terminal event. They are typically experiencing a severe migraine attack. Because the volume of the pain doesn't reveal the cause, doctors ignore the subjective level of hurt and instead follow a diagnostic flowchart to separate benign annoyances from lethal threats. The first mandatory step in that medical decision tree is ruling out what doctors call secondary headaches. These are symptoms of a much more serious underlying systemic disorder. To spot them, physicians look for specific red flags. A new, severe headache in a patient over the age of 55 warrants immediate investigation. So does head pain accompanied by a fever, which could indicate a systemic infection or meningitis. Then there is the timing. A headache that takes minutes or hours to build is common, but a thunderclap headache, one that hits its absolute maximum peak intensity instantly, prompts doctors to immediately check for a subarachnoid hemorrhage. This occurs when a blood vessel ruptures and begins leaking blood into the space surrounding the brain, requiring urgent neurosurgical intervention to stop the bleeding and relieve the pressure. If those specific red flags are clear, the risk of a life-threatening event is minimized. The clinician can safely move down the flowchart away from underlying diseases and focus on identifying the primary headache type. Almost all of these primary headaches fall into just two major categories that dominate the population statistics. 69% of them are tension-type headaches. Patients describe a tight bilateral discomfort, meaning it wraps around both sides of the head like a slowly tightening band. It builds gradually and is frequently tied to stress. 16% of cases are migraines. These behave as distinct episodic neurological events. Instead of a uniform band of pressure, the pain is usually unilateral, confined to one side of the head, and it throbs with your pulse. Doctors look for the classic migraine triad: one-sided throbbing pain, paired with intense nausea and a severe sensitivity to light and sound. Some patients even experience premonitory visual auras, called scotomas, where they see spots or flashing lights before the pain begins. Identifying whether you are dealing with a bilateral tension band or a unilateral throbbing migraine determines the clinical path. It tells the doctor exactly how long the attack is likely to last and precisely which intervention will stop it. On the rare fringe of the spectrum, affecting only 0.1% of the population, is the cluster headache. Patients suffer short-duration spikes of excruciating, searing pain right behind one eye, arriving in daily bouts concentrated over an 8 to 10-week period. You can often spot a cluster headache by watching the patient's behavior. While a migraine sufferer will seek perfect, motionless silence in a dark room, a patient in the middle of a cluster attack will be physically agitated, often pacing the floor in agony with a tearing eye. Other rare conditions are triggered by highly specific mechanical actions. A patient might experience severe head pain only when coughing, bending over, or physically exerting themselves. Curious, these extreme variants demonstrate that head pain follows a predictable biological logic. It is the result of specific mechanical and chemical stimuli, rather than a vague consequence of fatigue. This leads to the core takeaway of the diagnostic pathway. A headache is an exact neurological event. You cannot treat it reliably with a generic catch-all medication. Taking standard over-the-counter painkillers for a cluster headache or a highly specific variant like an indomethacin-responsive headache is often ineffective. The drugs simply do not act on the biological pathways causing the pain. But an accurate diagnosis allows for precision in treatment. For a migraine, medications like triptans or CGRP blockers are engineered to bind with specific neural receptors, interrupting the neurological signaling pathways at the source. But sometimes the solution bypasses pharmacology entirely. The most effective treatment for an acute cluster headache attack is placing the patient on high-flow oxygen for 15 minutes. As a patient, you are fully empowered to navigate this process. By paying close attention to your clinical profile, the exact location of the pain, the time to peak intensity, and the environmental triggers, you provide your doctor with the exact data they need. When you provide this level of detail, the fear of a mysterious underlying disease is replaced by a manageable medical strategy. You move from treating a general symptom to disrupting a specific biological process.